Billy, I got it.
Okay.
Thanks.
Hey, this is Melissa. I'm going to have to shut down my computer and bring it up real quick while you guys are doing that. I'll be right back.
Copy. And Carson, if I can get a video on you, then we've got a quorum.
All right, Dave, I see Carson. Carson, can you say something to make sure we can hear you?
Hello, can you hear me?
Okay, we got a quorum.
Where's Larissa? I lost her picture, I guess.
I'm here.
Okay.
Okay, somebody needs to take charge and move us along.
One of you board members need to go ahead and call meeting to order, do the roll call and stuff, and then we need to get to elect the chairman again.
I can go ahead and start it, but I by no means want to be the chairman. Let's go ahead and bring this meeting to order. We can have the roll call.
Lively,
Yes.
high school. Vincent,
Here.
Van Zant,
Here.
Okay, we have declared that there's a quorum. First item on the agenda is to elect the chairman and the vice chairman. Do we have any nominations?
I nominate Van Zant. Chairman.
Okay, and I'd like to nominate Elka for vice chair. Any discussion? Okay, call for the vote. Vote.
Okay, just be clear. Hold up, Billy. We have a motion to nominate Carson, but no second. Then we have a motion to nominate Ilka, but no second. So we need,
Okay, sorry.
yeah, it's okay. Just do one.
I will second both of those.
Well, you made the second one, so you can only.
This is why I don't want to do this.
Okay.
I second Ilka.
as vice chairman.
Okay,
As, yes. Cheryl, second Van Zant, please.
I will second the motion for Van Zant as chair.
Do we need that as two separate motions?
Looks like Corey stepped away.
Okay.
I don't think so. I think one motion for both would be just fine.
Okay.
Any discussion?
I'll get down there.
Now call for the vote.
Stop letting me go down there. What are you doing? Okay, Van Zant,
Yes.
Lively,
Yes.
Vincent,
Yes.
Now it's Carson's time, correct?
didn't I call him already? Van Zant, Lively, and Vincent.
I'm sorry, Billy, what are you waiting on?
All of you voted yes, right?
Yes, ma'am.
Yes.
Okay, in the effort to move this along, that means Carson, you can now take over the meeting from Cheryl.
Okay. Would somebody like to give me some hints on what to do here?
We're on the consent agenda, so you just have to read the consent agenda item and everything. The item 2, 3, 4, 5
Okay.
on the consent agenda.
So
And
on
then ask for discuss, ask if anybody wants to remove anything off the consent agenda.
Perfect. The consent agenda is as follows. Item 2, approve February 23rd, 2021 regular meeting notes. Approve February 18th, 2021 medical staff minutes. Number 4, approve February 11th, 2021 quality meeting minutes. Discussion and possible action regarding amending, adopting, approving, rescinding, and updating the following policies and procedures. All policies were made available to board members in digital format for the review and will be made available to the public as required in paper format at the hospital within 48 hours. Do I need to read all of these?
No,
Kim?
just get back to the, yeah, you don't have to read any of the rest of that stuff.
Okay,
Because I think that's all under that item 5.
perfect. Any review questions, comments?
Ask if anybody wants to remove anything off the consent agenda.
Would anything like to be removed off the consent agenda?
No.
No.
So ask for a motion to accept the consent agenda as presented.
Motion to accept consent agenda as presented.
I make that motion.
A second.
Now call for the vote.
Call for the vote, please, Billy.
Lively,
Yes.
Van Zant,
Yes.
Vincent,
Yes.
Now you're on the remarks.
The remarks and queries by the audience are not pertaining to any item on the agenda. The reports and information only and do not need to be approved or voted on. The CEO administer report.
Wait, hold up. Is there any remarks? Now give them time to see if there's any remarks not on the agenda. And then kind of delay, and if there's none, then move to number 6.
Okay, any remarks or forever hold your peace?
No.
No. Okay, moving on to the CEO or administrative report.
Okay, my name is Cindy Tillman. I'm the interim CEO for the hospital along with Kathy Hammonds. And I'm going to give you the CEO report. As you can see from my report, it's a little bit different. This is the standard format CEO report that we typically give. And then the quality, or we call it QAPI workbook, is included, which Melissa will go over. And that has all the department reports. So those are not included in the CEO report because she's going to give a very detailed quality report during her time. So I want to just kind of give an overview of COVID-19. We continue to participate in the daily Region 3 MERC briefings. Then we have asked Daniel in his CCO report to give detailed information about Mangum and the COVID-19 numbers, statistics, things like that. So he'll be giving that in his report. Of course, we continue to keep up to date on the most current COVID-19 information. We share that information with all of the staff, the providers. We have binders in each area to make sure that those most recent either policy changes or newest updated information is put in those binders for them to have access to. We participate in the vaccine planning meetings. The hospital and clinic, I'm happy to say, are approved as pandemic providers. So the clinic will start administering the COVID-19 vaccine starting April 7th. They'll have their first vaccine clinic there. So we're excited about that. And then, of course, they can use the email address for directing patients to vaccine sign up. To go over the hospital staff operations overview, I just want you as board members to know that in the last 2 weeks with the transition, that the staff there at the hospital has worked really hard. They've stayed very cohesive as a group. There hasn't been any chaos. They've just continued to do work as usual, even though there was a bit of a disruption with the change of CEO. They have not let that affect their patient care or the way they do their daily jobs. There were no new employees hired the month of February. Those open positions, of course, Cohesive's motto is to hire any local talent that is available. So we'll be looking at any local employees or candidates for employees. But if for some reason we can't find any, we can always pull from the Cohesive pool of employees to fill in the gap while we're looking for the right candidate. We continue to do the morning director's huddle each day. This past week, we offered to those who were comfortable meeting in the cafeteria the opportunity to gather again as a team. And a lot of those have chosen to do so. And I think it's been good for the staff to kind of be able to pull together as a team and do some of those meetings in person. But of course, those who wish to meet virtually can still do so on Microsoft Teams. Myself and Kathy Hammonds are on site each week as the interim CEO. We've notified vendors, the state health department, directors, providers, everybody that there's been a change in the CEO. And we are working on some of the meeting schedules and workflow with the staff at this time. I know some of the additional items that were on Marie's was the roof, and I know that's on the agenda to be discussed. And then the contract with the OBI, the Oklahoma Blood Institute, which is another agenda item that I'll report on later. And that's all I have. Do you have any questions?
I do, Cindy. I'm sorry, and I'm sure that it's a me issue. I don't have the reports that you're talking about. I don't have the CEO report or the CCO report, the financial report. I don't have any of those.
Did you download the packet?
Yeah, I tell you, it was a me issue. So no. Okay, never mind. I'll go back and look for them.
Okay, no problem.
Thank you.
You're welcome.
Any other questions?
Okay, Carson, you can go on to the CCO report now.
Now we'll have a CCO report, please.
Sorry, it took me a minute to get unmuted. This is Daniel Coffin, CCO of Mangum Regional Medical Center. What you have before you, if you can see it, is the standard Chief Clinical Officer report. From it, I'll share with you some of the highlights, sticking to the 4 pillars of success from cohesive healthcare management. The first pillar be excellent patient care. Monthly education topics included effective management of critical lab findings to ensure optimal intervention for those patients in a timely manner. Again, hitting some highlights coming up. We had our clinical meeting on 3/9. 3 different times there at 6:30, 1400, and 16:30. Effective March 11th, we were required to, we could change from the N95 masks in the general care area to a simple mask. Then, of course, we continue the N95 compliance for all the patients that are under investigation or confirmed COVID-19 cases. And the next pillar be excellent client services. Patient days did increase from 183 to 324 in February. Real good there. Census jumped up to about 11.57 per day. We're glad to see that. And coming up effective March 15th, in response to the COVID-19 pandemic, we all patients who are considered COVID-19 positive may not have a visitor. That hasn't changed. However, all other patients are allowed 2 visitors. Those visitors must be designated upon admission and remain the same throughout the stay. Patients will be subject to the screening process and make sure that they meet all those points to maintain compliance. Social distancing is always required. And let's see, that was the next pillar is to preserve rural healthcare. We were proud to say that we had 15 inpatient admits, 20 swing bed admits, 2 observation days, 133 visits to the ER. We completed 2,286 labs and completed 246 radiologic studies. And as far as preserving rural jobs, the final pillar is our open positions include a full-time respiratory therapist, lab technician, registered nurse, LPN, and CNA. So if you know of anybody looking for jobs, let them know. Mangum's a great place to work. Laboratory manager and RN interviews were completed. I am proud to say, since this report was generated, we have hired both of those positions, 2 more core staff members. We're proud of that. And MRMC dietary team continues to delight by offering delicious lunches that are free of charge to on-duty staff during this time. That should sum up my report. If anyone has any questions, comments, or concerns, I'll be glad to take those now. Thank you.
All right, next item.
Next item is going to be the financial report.
Very good. Can everyone hear me okay?
Yes.
All right. Before I get started, I want to say a couple of things. One, I really want you all to know how much I appreciate Andrea Snyder and all the work she did for that hospital. I think she has a tremendous work ethic and just as a classy lady. So I think we're all going to miss her from Cohesive, but I'm certainly happy for her. And I appreciate all the work that she's done for that facility. Crispin Ogama will be taking over, and Crispin is already getting his arms around everything financially at the Mangum, and I'm helping him and assisting him as well. But he'll be taking over in the future. I will be on every call, and I will be available for any follow-up questions or emails or anything else you have. So don't hesitate to stop me or ask me anything. And secondly, as we go through this, we want to walk through all these schedules every month. And so I'm glad we're going through that. And again, if you have any questions, just feel free to stop me in the middle. Let's go recap February. And February was a good census month. It was 11.6. We certainly didn't start off that well. We started off at about 5.9 in January. The reason why I want to bring that attention to you is because that impacts directly our cash receipts for February. I had to go back actually about 2 years and try to find a census lower than the January start, and I really couldn't. But 11.6 is a good rebound, and the target for that facility is 11. And what I mean by that is if we can maintain 11, then we shouldn't be in a situation where we have to worry about some huge Medicare payable or Medicare receivable, and we should be able to project our cash receipts and consistently on a monthly basis. So that's certainly a focus. Year to date, and what's also critical is the Medicare swing bed patients. On average right now, for example, for swing bed patients, we get 26.25 a day. That's our reimbursement from Medicare. The acute inpatient, we get 27.81. So it's important to kind of keep those numbers in your head so you can know what you're projecting if you're in my seat on what I should expect to get in cash just from that service line alone. So we started out late, or not off to the best swing. We had 376 year to date through Medicare, and you can look at the prior year, we had 629. So again, that directly impacts the cash receipts from February. But I think we try to isolate it, and I try to break it out for you like that. And there's some key stats on hand as well. But that's something that we track every single day. I actually do a projection for the month based on how we're trending throughout the month. So that's something we stay on top of. The next thing I try to focus on is the balance sheet. And I say this for any entity, because if your balance sheet's not right, your income statement's wrong, period. And that needs to be the item of focus and where I always start my reviews when I'm going through anything. So in February, we saw our cash balance drop about 804,000, but there's a couple of reasons why. Primary reason was we paid down about 364,000 in AP. And the second thing was we had the lowest monthly cash receipts, again, that we've had in some time, all census driven. The other impact on that, and I'll walk you through that later as well. What that means is if your costs are remaining relatively constant, but you're not getting your cash up front, you are going to get it later from Medicare. You're just not going to get it until you file your cost report. So again, if we drop materially low below our census, our target census of 11 throughout the year, then our concern is on our daily cash and our current cash. We'll eventually get it back to the cost report. On the other hand, if we're running above that rate, our concern is, okay, are we creating a payable along the way? And maybe we need to put some cash aside. So again, that's why those figures are so important, especially for a critical access hospital to track, unlike a PPS facility. So I want to talk about that piece. We also saw an increase in AR of approximately 180,000. Again, that was because the census rebounded. The Medicare principal balance, we also paid down on those, and we paid down about approximately 105,000. So we're paying off those Medicare ERS loans. I've got a separate tab I want to walk you through on that, and that's really also important as a board, keep your eye on, and it's something, again, for finance, we certainly track. So on your balance sheet, again, those are the key items that I've identified. You also notice, you'll see the reserve funds, and you'll see the COVID grant, and those are corresponding numbers. So that basically represents the dollars we've received from the CARES Act. So we record the asset and we record the liability, because if we don't use it or can't justify the use, then we have to assume we're going to have to pay it back. That's why there's a corresponding liability. If we are able to use it, then we can take that and report that as grant income, which is not something, doesn't impact us negatively. You actually get paid twice if you're a critical access hospital for the same thing. So you not only get your expenses covered, but you still get to claim them on a cost report. I don't know if they never figured that out or they just don't care to figure it out, but it's not something I'm going to complain about. That is an advantage that a critical access hospital has over a PPS facility. I can promise you that. The next, does anybody have any questions over the balance sheet? And I'm going to go through some more details. Okay, the next page is cash collections. And if you'll look, this has been, and Andrea did a really great job of tracking this for us. So if you look at the far right column, you should see 609,151. And you have to go back several months to see when cash was that low again. And again, that's a direct result of the current, of the January census that we incurred. Any questions on that? Can everyone still hear me okay?
Yeah.
Okay, good deal. Thank you, Carson, for letting me know. All right. The next page is a Medicare payable, and this is a breakout of this, and this is something to pay close attention to. And I'm going to walk you through the best I can. It's really promising from where we started to where we are today. In the middle, though, you'll see around 2017, there's still about 4.6 million, and you don't see any interest paid on that. This is part of, I think, most of the people that have been on the board for a long time. Those three numbers right in the middle where it says balance as of 228, the 1,614,000, with the brackets of 536, and the 3,539,000, those all net to about 4,618,000. 768 to be exact.
Okay, real quick, Dennis,
Sure.
I'm so sorry, but on our packet information sheet, what page are you on right now?
This would be the 7th page. So if you started at the very top, where it should have the financial, it has a list of the reports I'm going on, which says financial update, stats, balance sheet trend, cash collections was next. And the next page was Medicare payables and receivables.
I think it's going to be page 329.
Thank you.
Mm-hmm.
Perfect. Let me know when you're there.
I'm there now. Thank you.
Okay, so that's the breakout, and it's kind of broken out by year, and we do this on purpose. It's certainly for tracking purposes. And what happened earlier in December is that we received settlement dollars that were very favorable for the hospital, and those were used to pay down. Part of it we kept in cash, and we replenished the stimulus fund. The other piece of that was used to pay down some of these loans that were due to Medicare. So right now, we have 2 remaining loans that we are paying Medicare. We're paying on the $378,458, and we're also paying on the $1,058,920. And the reason why that's important is because we're spending $117,000 every month in just that debt service alone. The good part of that is the first one, the $378,000, that's a monthly payment of just under $60,000, and that will be paid off in September. So that's going to free up a lot of cash for the hospital in the future. But if you just looked at those 2 alone, that's annual repayment of prior year issues that we've kind of had to address, and it is what it is, of about $1.4 million a year alone. So we're almost out of that, and we're certainly headed in the right direction. I know that's rather complicated, but if you have any, again, follow-up questions, just let me know. Next page should be the income statement. And again, I'm going to try to just hit some of the highlights. I'm also try to bring things to your attention that I think maybe you never see in here, or you wouldn't think to look at or ask. So everything I can bring your attention to, I certainly want to do that. Gross patient revenue, again, is down compared to prior year. And again, that's primarily due to swing bed volumes. As I talked about earlier, we're at 376 year to date compared to 629. And the net patient revenue is break even. And that's primarily due to last year when we got a Medicare receivable, we weren't estimating that receivable throughout the year. So that was a little bit understated to some degree. And we have consistency in our overall cost. So cost is such an important driver of a lot of our net revenue because it's a driver of the Medicare piece. So that's important to note and keep track of. The other operating income is higher, but that's primarily driven to COVID reimbursed expenses. And this is, again, are things that are driven by things that qualified to be spent under the CARES Act, and we got paid, and we get to treat it as grant income. Our operating expenses are relatively close to what they have been historically, doing a little bit better current month and pretty close year to date. Not a lot of difference. The biggest thing and the best positive impact is down at the bottom, closer to the bottom, where you'll see the interest. And that's 27,000 less for the current month than what we were running. And it's 49,000 last year to date for what we were running. So that's a big component of why we're a little bit ahead, or why we are ahead of prior year. And the great thing about that is that that interest that we pay to Medicare is not even deductible or allowed on your cost report. So when you have to pay back Medicare, it's a double whammy. One, you're paying at about 11.625%. A second is you can't even claim it on your cost report. So it's like the worst financing that you can possibly get. And sometimes you just have to do that because you couldn't afford to pay the payable that was there. Any questions on that? Okay. The next page is just an income statement trend. What I want to make sure that you're going to see every month, and I realize there's only a couple of months, but we want to put this in front of you and the board and make sure you have an opportunity to look at that, because one, you need to see financial statements that are consistent, And if we see any material change between one month and another, it really helps it stick out like a sore thumb. You know, a lot of times if you just get high level and year-to-date stuff, there's a lot of different things that you never catch your eyes. But when you see it month to month, side by side, category by category, it certainly helps everyone in finance to review it. And it helps the board to understand the changes of what's happening between one month and another. It also helps you to see if you're heading the right direction. You know, so that's something. And then next month we'll have March and April and so forth. But I want to make sure that this is something you're start to get familiar with, and we'll present this every single month. The next page is a financial summary. It's got a lot of data on there, but it's also got some historical information. And what I want to start with is, if you look at the top, look at the heading titles. I think that's important. You know, you got February, January, and then you've got 2020, 2019, 2018, and you've got a column on the far right that says 6 months ended December 31st. And for everyone, and if anybody needs me to email the financial package or whatever, if you didn't get it or don't have access, I don't mind doing that whatsoever. So you can at least refer back to it. But next, at the very bottom, not the bottom line and not the next line, but right above it, you'll see something that says changes in net assets. And the critical piece, I think, when I look at something is, where are you going? Where were you and where'd you start with and where are you going? And you can go back and look, and 6 months in 2017, they started with a loss of $3.5 million. Then 4.8, 3.5, 2.8, and I think we have an opportunity to even get closer to the 2 million potentially this year. So I know it's not the best story, but it certainly shows a positive direction, especially when you look at where we started from, because that number is $7 million annualized if you go back to 2017. The next 3 pages, I think, or 3 or 4, maybe 4 pages, yeah, 4 pages. This is a AP aging, and this is important for anyone. I mean, this ties out to your balance sheet. I've already checked that. It's something Andrea did a great job of tracking, and Crispin has the same work ethic as Andrea. So I think you're going to learn, if you haven't had a chance to work with him already, appreciate him as much as I do. He's just tremendous worker. But I've tied that out to the trial balance and to the financial statements. So that breaks it out between what's current, 0 to 30, 31 to 60, 61 to 90, over 90, etc. You can see we have a large amount out in the outstanding, greater than 90 days. Obviously, that's not something you want. It's not the prettiest picture, but again, that is the reconcile what it is, and that is by vendor. And the last 3 pages I have to cover, I think it's 3, yeah. This is something Andrea talked to me about. And basically, it's my understanding that we need to present like an estimated claims for each month in advance. We're certainly not going to spend that amount, but we need, basically my understanding is I believe we need approval to, or at least this has to be reviewed and make sure we don't ever exceed this. And we will not, our AP is not that high. These are just proposed. Any other questions? Or does anyone have something, or if there's something else too, just if you think of that you'd like to see in addition to this? I'm just want to make sure I put the important pieces right in front of you, try to create all the transparency I possibly can so everyone can see it, themselves. And then, if you think about something later that you want to ask, just let me know and I'll try to get a response back to you as soon as I can.
Do we have any questions for Dennis? I would like to say thank you for putting this together for us. I know this was an awful lot, and I want to say thank you to Cohesive for getting all this together. This is very helpful to let us know. Really quickly, for February, do we have how much was our total income or accounts payable that we are bringing in for February?
What is the AP spend?
Yeah.
Or are you talking about cash receipts that we expect to get, or are you talking about AP, what we expect to spend?
I'm gonna want both, but I'm gonna want to know how much did the hospital bring in for the month of February or expected to bring in? And then how much did we spend?
Well, we brought in, as far as cash, Carson, that 609,000, I think that I put, it was 609, and our expected spend is going to be, hang on just a second, because I'm trying to back out payroll here. About 750,000. It looks like between 750 and 800,000. It's a ballpark without sitting here doing the math myself.
Thank you.
You're welcome. Obviously, and one of the things I do, like for example, right now our run rate is at 8.6 this month for for Mangum. So again, we want to get to 11. And so our case management team is working diligently to make that happen. And I really they have done a great job on doing handling that piece of it. So certainly want to acknowledge all the work that they've done.
Very ignorant question. How does one go about raising that rate?
Well, your costs are your main driver of your rate. So any increases in your cost are going, and it's also a combination of those things. It's a combination of cost and volumes. But unfortunately, the piece that you want to realize is that Medicare is not paying you for some premium. They're not paying you a profit. Okay. So you have to really try to make it in all the other areas that you possibly can. Medicare is more on these critical access hospitals trying to keep them alive and saying that we're going to try to reimburse you your costs. And that's the best high level I can try to give you. Before, they were also doing a 2% sequestration. So even then they were taking that piece out. And then if you are a Medicare patient, you may have co-pays and deductibles. And those are usually higher on, especially the patient side. So part of that responsibility of, even if someone were to pay you your cost, part of that is being pushed over to the patient to pay, more so on the outpatient side. On the inpatient side, the swing bed and inpatient side, Medicare pays most of that. So those rates that I gave you before of the $26.25 and the $27.81 per day, Medicare pays most of that. There's not a lot of co-pays or deductibles in that. But on the outpatient side, there certainly is.
Dennis?
Yes, ma'am.
I'm sorry, and here I go with another stupid question. So if our expense is between 750 to 800K a month, at least for February, but we brought in 609, what kinds of programs are we looking at to bring in that will help supplement or bring in new dollars?
That is a great question. So there's a lot of things that we are working on. 340B program is certainly one, and that's one where whatever we can collect from there, we get to keep. That's a very positive. We're also have just gone and approved for the RHC status, and I'll discuss that a little bit more and tell you some numbers. I can tell you right now and give you some estimates on that, but
Okay.
Jamal's going to go into more details. I'll tell you the cash based on the rate. right now I'm projecting about 335,000 positive to the hospital on an annual basis. At minimum, if they cap it at $100, which we don't think is going to end up happening, and I'm getting a little ahead of the game in somebody else's discussion, that's about 65,000. The Strong Minds piece is really good for all of these facilities in critical access. And one reason why, and that's a geriatric program, is because it is such a heavily utilized Medicare area. So what that does is it helps to drive more of the cost to Medicare, and those become reimbursable in your cost report. So that's another positive. So it's nickels and dimes, and it's searching and it's finding piece by piece, but hospitals are accumulation of all the small pieces. You know, that's why every department is analyzed and looked at. It is a sum of the pieces. And when we're building anything, any pro formas or anything, it is the approach that you have to take.
Okay, so then, because I don't know the lingo, if I Google 340B or RHC status, is that going to give me some more information, or do I?
Absolutely. Yes, it will.
Okay.
And,
okay.
Or you can call me, or I can email it to you.
Well, all right.
We've got a lot of really good people throughout Cohesive, and affiliations with other groups that really have a wealth of knowledge in those areas as well.
Okay. All right, cool. Thank you, sir. I appreciate it.
You're welcome. And the good news is it's not just limited.
And I'll just I'll read we have a growth team.
Jamal, your sound is really, really bad.
You sound like a Decepticon.
Nope, it's still pretty bad.
Any more questions for Dennis from the board?
I'm good. Thanks.
Again, Dennis, thank you for putting all that together for us. At this time, we'll move on to the clinical operations report.
Good evening, everyone. This is Christy. Can you hear me okay?
Yes.
Okay, perfect. You have the clinic operations report for February. Just wanted to highlight a couple of things of note. The clinic manager monthly meeting, we focused on referrals, the referral process, and all of the clinic managers developed a referral sheet for patient satisfaction. That was brought up that was a wish from the patients, is more information on the referral process. So we put that paper together. In addition, nurse-only visits, we did discuss that as well. And then I did want to speak a little bit about the quality improvement. Chart review did show that there were 8 demographic registration consent errors. Those have been addressed. Education was provided, and we are trending no errors for March so far. So that is good news. Visits per productive hour did go down in February. These are the RHC visits. So due to some of the weather days, some of the visits were converted to telehealth, which would not show on this count. So that's why the number dipped a little bit for February. And are there any questions?
I'm sorry, I have just a really quick one. Do we
Yes,
have a big showing or a big following for telehealth?
Typically, it has been off and on during COVID. There have been surges where the telehealth visits are increased and then where they are very minimal.
Okay.
So
I was
this just
curious.
happens to be.
I was just curious because I use it a lot. and I've got elderly neighbors who are not internet savvy, I guess. And
Correct.
it just seems like it's an opportunity to get people involved in telehealth that will be beneficial to them.
Yes, absolutely. And the clinic has certainly mastered the process. So we just happen to see an increase of the telehealth visits in February because of the weather. So we think that has a lot to do with it.
Thank you.
Thank you.
Any more questions for Christy? Okay, then let's move on to the February 2021 quality report, please.
Okay, I will go ahead and get started with first of all, I was wanting to explain this to you guys. We've never used this one before. I don't know if you'll have it in front of you. It has a really good look to it, cohesive. IT worked really hard on getting this, and our IT has helped as well. And it's a really good piece. That way it makes it easier just to look at, and you guys can see where we're going, and you know, not just a bunch of numbers, but you can even look at it as well with the graphs. And we'll just start off with a hospital activity. And you can see that is up from January, which we've talked about, which is a great thing, not just a good thing, it's a great thing for us. And then also in total discharges, ER visits, and average daily census, we are up on all three of those as well, which as everything climbs together, it works that way usually. Everybody's getting out now. And if you'll move down to the hospital activity under the AMA left without being seen, you notice that his went down one. There were 2 in January, and then there's this one in February. And on that one, it had a patient family member that had been seen in the ER and had been triaged, and we were doing all the things that we were supposed to do to treat the patient. The patient had a family emergency at home while they were in the emergency room. They had a family, they had to leave, and the providers and the nurses did explain to the patient the leaving and the benefits of staying, but the patient still had to leave. They did sign the AMA, which is required if we can get it from people. So that was taken care of. Let's see, we just spoke about that. The 30-day readmissions, we didn't have any readmits for the month of February. And under the risk management tab, there are 6 incident reports, which in that like the AMA is in it, the falls in it, you know, that we'll talk about here in a minute. But that's just like incidents that happen in the hospital. And there were 6 of those. And the little chart under it, it's not color coded yet. We are working on a few little minor details like that. But it was just nursing department, which ER is considered nursing, and, you know, inpatients and everything. But that's where that little graph is showing that. And then under it, it also shows the same kind of things. But that one actually groups together as we go, like that'll be January and February as the incident report categories. You can see the patient fall without injury this month, and then the 2 AMAs from January and the 1 coming, and then the other events add up to the 7. But you'll just see that as we go through the year. We're just getting started. And just in saying that about the patient fall, we'll go up under there. There was a patient fall, and it was a patient fell with no injury. The patient just didn't activate the call light, and everything worked out okay. The patient was assessed and put back to bed. Everything worked out great for the patient. There were no complaints for February, but there was 1 grievance. Actually, I have that backwards. There was 1 complaint for, and that grievance was back in January. And actually, me and the CCO went to speak with the patient, and all the things that the patient had wanted to talk about, we resolved them at the bedside, and everything worked out for the patient, and the patient was happy. There's again with the graph with that 1 patient fall. And you'll see that the ER patient falls are empty for January and February. That's because we have had no falls, which is great. And if you move to the mortality rate, there was one in February, none in January.
Melissa, do you guys track when people call in to get information from the emergency room rather than come in because of COVID? Is there a way, do you guys track that?
Well, we don't track that, but if someone was to call in and want to know, you know, do you mean kind of like if they should be treated for something? Is that what you mean?
Yes, yes.
Okay, so really in that, we would never treat someone over the phone or test do come in, or that if they feel like it's an emergency, then, you know, we wouldn't want to tell them on the phone, you know, no, I don't think it's an emergency. You know, you see what I'm saying? We would always say, if you feel like it's an emergency, to come in. We don't give any medical advice over the phone. You know, we don't, it's not like telemedicine. I bet that's what you're kind of going for. Is that where you're heading at? Telemedicine?
No.
No, I don't know exactly what, like, we do
So-
not track calls for the ER for, you know, for questions.
Okay, now I would imagine certainly early on with this COVID that people were not wanting to come to the hospital or to the emergency room because they just assumed that's where they were going to get it. And so I
Oh, I
was
see what you're
wondering
saying.
if we had any kind of tracking information to see if, you know, the number of calls that were coming in with whatever their issue was, so that they didn't have to come into the hospital. That's what I was asking.
Oh, okay. Yeah, and they actually had a really good system in place with that. Even when they called, we would explain to them, you know, we would either come out to their car if it was something, you know, to take the blood pressures or different things, to triage them if we had to in their car, if they were to that point. So we had a pretty good system in place to take care of that, because yes, that's a good question, because people did have a lot of worries and concerns at that time. But yeah, we had a system in place to take care of that, but we did not track any of the calls, basically because we took care of it as we went.
Okay, I guess I'm asking that question because I think on the last meeting call that we had, one of the things that we talked about was a survey system, and contracting out a company that was going to do the survey system. And I was just wondering, what survey did we do in-house?
I know what you're talking about, like the Press Ganey you guys approved last month.
Yes.
But yeah, those are not actually like that. After we see the patient, then they will contact them. So yeah. You're putting it together. Yep, that's right.
Okay, so I'm sorry, I'm just
Hey,
curious. Okay.
No, you're too. We're all going to get this together. Let's see. And let's move on to, well, under the mortality rate, what that life share organ bank notifications within 60 minutes of death. We have time frame to call, you know, for that if there was an organ donation possibility, or we call in every one of them. But we did within the 60 minutes. And let's see. Okay, we'll move to the medication report section. And on that, there were 5 med events. See, all 5 of them, if whoever was involved in it, whether it was it's the staff of the hospital, any kind of nurse or anybody involved in it, was re-educated. The CCO is he's very good about re-educating and letting them know where it went wrong. Even if it was a little something, he still re-educates them and lets them know the proper ways to do things, or charting, and so that was all done. Infection control and prevention. If they stay at benchmark, you won't see much going on. You know, just like under here, I did go ahead and put that there were no CLABSIs or CODIs, and that because that is kind of the bigger events. But if they may meet on a lot of other things, then we won't have anything in there really to report. Let's see, the health information management. If you see a drop like this, like we've seen history and physical completion, let's look at that. I'm not sure. It's actually not dropping. It's just showing that, okay, because there was 100% on that one. Yes. Discharge summary completion. You'll see that one just has a little decline. And that is a signature that didn't get on the paperwork. And we actually have a way for the the providers to access, and they can sign that. So they're working with getting that provider to get that discharge summary signed. And we did have one code blue, which went with the death that we had for February. And on the transfers, there was inpatient transfer because of a higher level of care. And then we did 10 ER transfers. 6 of them were a higher level of care that was needed. And 2, they needed a surgical repair. And 2 of them, we also had some issues with the heat in the COVID rooms. And it was during the really cold time. So we did not even want to keep anybody that, we didn't want to keep warm enough or comfortable enough, because that was before we had got all the Reyes electricity issues out and fixed. So now it's all ready to go, but that's where we were in February. And that's why we had sent those 2 out, which explains that over there to the right. I think that's pretty much it, unless you guys have any questions for me about the report.
So I do have a question here.
Sure.
It says that on the transfers, the ability to keep the COVID wing due to breakers not being able to hold enough current on several items at once. An electrician is due to come out ASAP. Who did we call for that?
Well, that was that Reyes electrician that we talked about last month. That was what that was for.
Is that?
I don't know if you remember.
So is this from like back in January, or was this?
No, it was back in February. This reporting is all for February, and it probably is a little bit confusing because we did talk about the Reyes electricians. I cannot talk. They were coming out to make the repairs, and this was before that happened. And that's kind of some of the reasons we got them out there so quick.
So this issue has been resolved already?
Yes.
Okay.
It was actually resolved in February.
Okay, cool. And I would also like to say thank you for the graphs. It makes it super easy to kind of tell what's going on. So thank you.
It does.
Please let whoever did that know they did an amazing job. And thank you. Any other questions?
Yes, they did. And yes, and it will make it easy.
Okay, if nobody has any other questions, we're going to move on to a couple other items at this time. We're going to move on to item number 11, discussion and possible action to remove Zach Zachary and Marie from the First National Bank and Trust hospital bank account. I would like to make a motion that we remove both these people from the bank account immediately.
Second.
Roll call, please. Or do we need a discussion? Does anybody want to discuss this at all, or are we ready to vote? Okay, let's vote.
Lively,
Yes.
Vincent,
Yes.
Van Zant,
Yes. Okay, it looks like that motion passed. Let's move on to number 12, discussion and possible action regarding.
Carson, if I may, real quick.
Yeah.
As a standard practice, the chairman shouldn't be providing motions. I mean, it can be done, but I would ask for a motion first from another party member.
Roger, that will do. Thank you, Dave. Moving on to number 12, discussion and possible action regarding the review and approval of the Oklahoma Blood Institute agreement.
Okay, I'm going to report on that. The Oklahoma Blood Institute contract is an existing vendor, so this is a renewal. We've had a contract with them since August of 2016. And the type of services that we receive from Oklahoma Blood Institute is the procurement of blood components, and some of the related services. We obtain our blood components that's required by the hospital for its daily operations. These products, of course, are only for the use of the hospital. OBI provides these blood products and services 24 hours a day, 7 days a week. They also provide services that include a reference lab, testing services, and medical consultation if needed. And so what we do, the hospital has a minimum standing inventory of transfusible blood products that they agree upon with OBI, and that inventory is maintained at the hospital. There is a fee schedule that was attached to the agreement, and I did check with AP, and the monthly invoices are typically around $2,500. And the fee is usually based on like what inventory is used. There can be extra fees at times if they have to deliver emergency units. I don't think that happens very often, but if they do, there is a fee attached to that. The term for this agreement is it will begin once it's signed and continues through July 31st, 2026. That's the initial term. After the initial term, the agreement automatically renews from year to year unless a party provides written notice of termination.
Wash your hands. Wash your hands. Okay, thank you. Oh,
So they
sorry.
That's
Sorry.
okay.
My son.
Okay. They would have to provide written notice of termination at least 30 days before expiration of the term. And termination clause, to summarize that, a party can unilaterally terminate this agreement if A, the other party fails to fulfill any one or more of its obligations under this agreement, and the breach continues for a period of 30 days after non-breaching party sends written notice. If any of the regulations are amended in a way that precludes a party from performing its obligations under the agreement. C, if a party ceases to operate or otherwise function as a business. Or D, if a party fails to maintain professional liability insurance as required. OBI may terminate this agreement upon notice if the hospital's state license to operate is suspended or terminated or revoked by the State Department of Health, or if the hospital is excluded from participation in Medicare, Medicaid, or any other federal health program. Upon termination, the hospital shall pay OBI any and all amounts owed for the blood products and related services within 15 days of the termination date. That's the clause in there for termination. So again, this is a renewal. It's an existing vendor we've used since 2016, and I've not heard of anyone that's unhappy with this company. So we would like to carry on with the OBI contract.
Any questions from the board?
Just as a point of order, any of these renewals, if they are simply a renewal, we can put them in the consent agenda. And therefore, we really don't have to talk about them because we've already done that in the past. So for the future, we might make it go a little faster.
Okay.
If nobody has any questions, first, Laretha, great advice on washing my hands. I will go do it as soon as I can. But thank you.
I'm constantly telling him when he walks to the kitchen, wash your hands, because I don't want to yuck. So anyway.
Well, great advice. Thank you. But let's go ahead and let's call for a vote at this time.
We need a motion.
I make the motion to approve the Oklahoma Blood Institute agreement.
A second.
Okay, let's call for the vote.
Lively,
Yes.
Vincent,
Yes.
Van
Yeah.
Zant,
Yes. Okay, next on the agenda is discussion and possibly becoming membership in the Greer County Chamber of Commerce. The item requested by a board member, and then the regular membership is 2,500.
I've got a question about this for Corey. Can they actually vote on this? Because I don't think Laretha can actually vote. She would have to abstain from this vote.
Whatever.
Yeah, I mean, that's what I was going to say is my advice would go ahead and table it because I don't think we have enough board members, I guess.
And I don't mean to be a pain. I'm just saying, as the Laretha, you can certainly give your reason why you would have to abstain from this, but there's not a majority of a vote after she abstains. So we may have a quorum here, but we don't have a majority to be able to approve something like that.
I get it. No problem.
Would anybody like to call for a motion to table this issue till next month?
No motion is necessary. You can just say it's tabled.
Okay, it's tabled. We're going to move on to old business discussion and possible action on the hospital roof agreement with the city. Who will be presenting that?
Carson, this was something that's already been voted on. Y'all have voted on it twice, actually. The city's voted on it twice, but we just got some things out of order. So this is the city's approved this. And so basically this is that same agreement on getting the roof started. And y'all just have to do your final blessing is all you're doing. So there's really no discussion on this because we've already discussed this. And I mean, I've heard it 4 times already. So, I mean, I would just ask that, you know, my advice is that there's no new information here. It's all the old information. It's just now that the city has approved their half, you're just approving your half. Does that make sense? Because originally you approved the agreement was always half and half, but we forgot to get the bids approved on the city side. And so we had to go back and get the bids approved on the city side, and then they had to approve it. And so y'all have already done it. So now you just have to approve it. Hopefully I confused you.
No. And I know this needs to be done. So I make a recommendation that we approve the hospital roof, the agreement with the city.
I second.
Let's call for a vote, please.
Van Zant,
Yes.
Vincent,
Yes.
Lively,
Yes.
Okay, let's move on to discussion and possible action regarding changes to the agenda and presentation of data presented by board member Haskell, specifically to remove all financial reports from the current format of the consent agenda and make them a separate item on the agenda to be presented monthly. This was tabled from last month. However, it was brought up in the following meeting on February 23rd, 2020.
it was actually discussed in the one before, and then you guys tabled this one. I'm not sure why.
So really you can take no action because I think that's been remedied.
Okay.
And even if it isn't, we're once we get back into contact with Ilka, we'll find out if she's good with the format now.
Let's move on then in discussion and possible action to enter into executive session with regards to the accreditation of the doctors in accordance to Title 25 OS 307 B1, credentializing these doctors. I don't think we have to go into executive decision. We just can go ahead and vote. Is there anybody from like Cohesive that wants to say any words or any problems that we need to be aware of before voting on this?
If we're going to talk about these people, that's when we need an executive session. Does that make sense? When you're talking about them, that's when you need executive session. So if there's going to be discussion, we have to do it in executive session.
Would anybody in Cohesive like to say anything that we would need to go into executive session about these people? Does any board member have anything that they would like to say where we may need to go into executive session?
No.
Do I hear a motion to go ahead and re-credentialize, well, I can't say that word, these three individuals?
I move to re-credentialize them.
I'll second.
I think you actually have to say the word re-credentialize.
Oh, well, I was going to try to avoid that.
I thought I said it.
Oh, you did, girl.
Credentialize.
I was just giving Cheryl a hard time.
Oh.
Okay, let's call for a vote.
Lively,
Yes.
Van Zant,
Yes.
and Vincent.
Yes, ma'am.
Okay, item number 17, discussion and possible action regards to litigation with HSO and First National Bank of Veneta MedSurge, wherein the advice from the attorney such as discussion will seriously impair the ability of the public body to process the claim with the possible executive session and coordinates. Okay, Corey, what do you got for us?
We need to go into executive session, so we need a motion to go into executive session.
I make a
And then
motion
we'll
that
all
we
get
go
kicked
into
out of
executive
this meeting.
session.
Let me put my
Is that
glasses
really-
on. I don't know what that is.
Do we have
I
a
make a
second?
motion that we, okay, you got it first.
I second. Let's go to executive session.
Copy. Corey, I need a list and go slowly because I'm going to have to add them as you say them.
Well, first we need to go ahead and do the vote on the executive session. So
My apologies. Billy, would you call for a vote?
Lively,
Yes.
Van Zant,
Yes.
Vincent.
Yes.
okay, so it needs to be me, Laretha, Carson, Cheryl, Dennis,
Corey, I don't know what this is. I don't know what that's saying.
okay, well, we'll talk about it in executive session.
Okay.
Michael Linscott, John Brightmeyer, and Jamal.
Okay, that is my list. If there's anybody that needs to be added on, please say the words now. Okay, I'm opening the rooms. When you will see a screen pop up on your screen in front of you that says go into a break room. When you go into that break room, you're not going to be able to be heard by anybody that's outside of that break room. I'm letting you know that so that you understand anything that is said inside of the executive session cannot be heard on our live stream or by anybody who's back out here in the main lobby, what we'll call the lobby. So does everybody understand that?
Oh, we're going to do that right now, David?
That's going to happen right now. I'm about to hit the button and you just enter into the executive session room.
Okay. Damn it. Oh, what does that say? Join.
And everybody that's left in the lobby, feel free to go ahead and turn off your video cameras because we're just going to be here for a while.
Can you guys see me?
Yes.
Yep.
Okay, do we have everybody back?
Nope, waiting on Larissa.
Okay. We'll give her a couple minutes and we'll see if she joins here.
Aretha is here.
Bam!
Welcome back.
Thanks.
Now, Carson, you have to declare us out of executive session.
I declare us out of executive session.
And now we're on item number
Where's my
19.
phone? Hold on, let me get my phone and my glasses.
Discussion and possible action in regard to executive session number 2.
No action.
No. Okay, so there is no action needed.
No
here.
action. So now we go back. Now we're on number stat.
Okay.
The remarks and inquiry session.
Are there any remarks or inquiries by the governing body members, city manager, city attorney, or any city employees?
Nothing from the city.
Corey, anything from you?
No.
Anybody have anything else?
Nope.
Okay. Moving on. Any new business?
No new business.
Okay. Do we have a motion to adjourn?
I motion.
I'll second.
Hey, and David, can I call you when we hang up real quick? I just have a quick question.
Yes, go ahead.
Okay.
But-
Call for a vote, please.
I vote, we adjourn.
A vote we adjourn to. Cheryl, do you vote? that-
Wait, we have to let Billy call for the vote.
Oh,
Yeah.
Billy, you're muted.
Lively,
Yes.
Vincent,
yes.
Van Zant,
Heck yes.
And we're
Thank
adjourned.
you all.
Meeting is over.
All right, everybody
Bye.
leave. Go home.
It was a pleasure to meet y'all. Take
All
care.
right.
Thank you.
Bye.
Thank you, guys.
Thanks.